Okay, welcome back. This is part 2 of PARM 2223, Unit 12 lecture on end-stage renal disease, chronic kidney disease, dialysis, and everything having to do with how you pee. Okay, because, we're all paramedics here, we're all grown adults, and who doesn't like a good, pee joke, right? Well, almost everybody, except for that one time in Saigon. Not going to go over that again. Okay, all right. So dialysis. So what is dialysis? So basically, dialysis is a mechanical, chemical replacement or substitute. I shouldn't say replacement or substitute for the normal diuresis that occurs that is performed by our kidneys. It's artificial. It can occur both inside the body and outside the body. We'll talk about that in a minute. But basically uses the process of diffusion and osmosis to cause dialysis. So you have a semi-permeable membrane, and you have the blood on one side of it, and you have what we call the dialysate, or the wash, on the other side of it. And the dialysate, the wash, is not it's not just water. It's a specially formulated compound designed to use the pulling power of diffusion and osmosis to shift water from one side to the other and to shift waste products and electrolytes, excess electrolytes and stuff like that from the other side into dialysate, where it then is disposed of. So if you remember, again, another one of those things like I talked about, you think, why will I ever need to know about diffusion and osmosis ever again in my career? Why do I have to learn about this? This is a reason. So osmosis is the movement of the solute, which in this case is all the waste products, from an area of high concentration of waste products in the blood to an area of low concentration of waste products in the wash. And the idea is that they will eventually equalize to a acceptable level for the patient to tolerate. Diffusion is the movement of the fluid, in this case usually water and some other compounds, from an area of low concentration in the wash, where there is low concentration of waste products but high concentration of water, to an area of high concentration of waste products in the blood. So as the waste products move from the blood to the wash, fluid shifts in reverse to a point where they both will eventually equalize. And the balance of this is getting that point of equilibrium at a position or at a level that the body can tolerate it. Does that make sense? There's another example. Here we see this little video illustrating this. So I hope that helped illustrate the process a little bit. And I'm not sure if you got the lovely faux classical music playing that I had the pleasure of listening to, but if you did, you're very welcome. Okay. So he's talking about the wash. The wash is the dialysate, and it's made up of the. It's designed specifically to pull the waste products over across the semi-permeable membrane, shifts some fluid back, but not so much. It has bicarbonate as a buffer, so it helps correct acid-base imbalance. Has sodium. It has other things that are specifically added, or and I shouldn't say added because they do sell this in bulk. So there's some standard compositions, or it can be custom made by or custom prescribed by the physician, or a combination thereof. Has dextrose, and it is sterile. And that's basically how it is. So when you go and pick up these patients, one of your important questions is, are they getting the same wash? And is, did they proceed through their whole dialysis treatment? Because different things happen at different times, where they could actually be fluid overload because they had a fluid shift that wasn't pulled out. Also, heparin is added to that. Forgot to mention that. Let me look at my notes here. My notes here. Let's see here. Yep. Okay. So let's talk about the dialysizers, because I think this helps illustrate the process of what we're talking about. And we've come a long way. These things have been around forever, since the 1920s and 30s. One of the earliest advocates and designers and physicians specializing in this was Dr. Willem, as in like Willem Dafoe, Willem Koff. He actually didn't die that long ago. He died in 2009. He was a physician and was son of a physician. He's a physician himself. And you have to understand that before this, before dialysis, these patients would just die a slow, agonizing death. And during the Second World War, he managed to prolong the lives and quality of life for about 15 patients. Now, they all died, but they all had temporary clinical improvement, and that was kind of proof of concept. And then after World War II is when the resources were available to really start pushing this. Also, incidentally, this guy was also very, very key in development of the artificial heart. If you remember, we talked about total artificial hearts and so on and so forth. He was also key in that. So here was his original dialysis machine in the 1930s. And what you see there, those straps, has actually sheep intestine as a semi-permeable membrane. And the one thing that strikes me about this, because blood would be pumped through that, the one thing that kind of strikes me about this is really kind of bizarre is the amount of blood they had to probably pull off the patient to make this work. And I'm sure that I haven't found anything specifying that, but just strikes me as somewhat stunning. So this one was from 1930s. We used up until 1943. Yep. This was actually, anyway. So in the 1940s, during World War II, there was a shortage of materials, especially for experimental treatments like this. So he had to use improvised materials, same doctor. And what was interesting to me, this is actually an apricot tin. This is from food rationing. This is a large apricot tin with cellophane sausage casing inside to mimic the kidney, and he'd make his own wash and so on and so forth. So this guy was pretty dedicated. This was the 1940s. What's interesting is this was the machine he actually brought a woman from the brink of death, and she survived getting weekly dialysis treatments for about 7 years until she died of another ailment. So that's definitely a proof of concept. The Brigham Hospital in Boston pioneered this with them, and this was actually what really took this off. As we talked about how sometimes conflict can impact medical advances. When soldiers came back from the Korean War in the 1950s, what we saw is a lot of them were dying of renal failure from rhabdomyolysis from shock, crush injury, from burns, so on and so forth, and hypotension. And that's when his interventions for the acute renal failure stage became rather essential. This is the 1960s. This is the first, what they call the drum dialyzer, which is actually the technology that is largely used today. It uses less blood, as you can see, but larger volumes to dialysate. And this is an example of a modern dialysis machine. It uses far less blood. Uses a fair amount of dialysate, which you can't see in this picture, but it's in a big jug below. Blood is cycled through, very similar to ECMO. Very similar to ECMO, is warm, is humidified, is also heparinized to prevent clotting and lysis of blood cells as is processed through the wash. So modern hemodialysis, all the dialysis, is typically a slow process. Takes about 3 to 8 hours, but it's not always done in facilities. Now, as pre-hospital providers, that's where we're going to encounter these patients, often at these facilities. But there are patients who get dialysis in the home, especially overseas. And I'll qualify this with saying that in countries that do not have large dialysis centers, the poor die of kidney failure, and the rich buy a dialysis machine that a nurse helps them get their dialysis in their home. That is quite common. So there are people in the United States that get home dialysis. So types of modern dialysis, as we talk about in-center, so this is either in the hospital emergently, in the ICU, or in these dialysis centers like DaVita and some of the other ones. Conventional home dialysis, which is what you see there. You see a gentleman with his home dialysis machine cooking away, very small, very portable. You have people that get short daily dialysis. Again, this is really most common in the emergent setting. You have people that get nocturnal dialysis. Now, nocturnal dialysis, I'm going to talk about in a few minutes. The idea is that it mimics, let me back up. So, kind of interestingly, a lot of our kidneys work is done when we are asleep. And the reason for that is when we are supine, our renal perfusion increases, and therefore the kidneys are able to do more of their work. This is why you wake up with a full bladder, or have to wake up in the middle of the night with full bladders and have to go to the bathroom. So there is a theorem that you can get nightly dialysis or every other night dialysis that will more closely mimic this process, and your body will tolerate it. And then there's something called peritoneal dialysis, which I'll talk about in the next slide. Now, peritoneal dialysis is distinctly different from hemodialysis. And in essence, it's a port very much like a peg tube that goes into your stomach, except it goes into your abdominal space. You remember how I talked about with ascites, fluid shift, and how it's very vascular? We're using that process to our advantage. In this particular case, the patient will plug in a bag of the wash, the dialysate containing solution, hang it by gravity to flow into their abdomen. It will sit there for a prescribed period of time using the intestines and the other walls of the mesenteric lining of the peritoneum and so on and so forth as the semi-permeable membrane, and the fluid shift will occur naturally. So anyway, so that's pretty much what that's kind of a continuous. There's a couple different ways they can do this. There is the gravity method, which is what I've seen most common, which is the continuous ambulatory peritoneal dialysis. So they'll plug this in, they'll let the wash go through, they'll walk around with their IV pole if they have to, and it'll drain by gravity. Sometimes what they'll do is they'll flush it in, they'll get very distended, let it sit there for a prescribed period, and then hook it back up to gravity and allow it to drain out the contaminated waste product rich fluid, removing it that way. This very low-tech method, by the way, is sometimes what you'll see in third world countries and stuff because of the problems with having more complex issues, power supplies, so on and so forth. You also have automated peritoneal dialysis exchanges where the patient, again, I talked about nocturnal dialysis, and that's where you see this, where they will do this at night during the hours of slumber. Of course, they have to be very careful they don't get this pulled and tugged, and it's secured in certain ways, and so on and so forth. So when you look at the port, this is what it looks like. It looks, honestly, if you didn't know what it was, you might confuse it for a peg tube. But the problem is, of course, you can't put tube feedings into this because you'll cause a peritonitis. There you go. So what's the biggest concerns? Infection. If this is still a somewhat a sterile process, the fluid has to be sterile, the tubing has to be sterile, has to be clean, because you're inserting this liquid into your peritoneal space, and any bacteria you take in will run rampant. It's a warm, dark, vascular breeding ground for bacteria if you let it get in. Another one is hypernatremia. Because this process, it is an automation. I don't mean to imply that there's increased accuracy with automation, but there certainly is increased precision. You can sometimes have fluid shift and too much sodium go across. You have hypernatremia, and by the same token, you can have either hypo or hyperkalemia. Another problem is dislodgement, especially at night, which of course can cause all sorts of problems. You can have a hernia develop around the site, and you can get hyperglycemia because the solution usually contains the dextrose. And the big thing, of course, you can't use a PD catheter for medication access, which we should know that. So the peritoneal dialysis catheter can get infected, and just like a central line or anything else, you get these keloid scarring, get this infection, you get this junk around it if it's not properly cared for, which of course, depending on the larger environmental concerns of the patient, is always a concern. There's an example of what infection may look like with its keloid scarring, and it'd be hot to the touch and may or may not have drainage. So I'm going to take a stop there. We're going to pause this video, and when we come back, we'll talk about problems that you encounter with dialysis. These are the acute complications of dialysis.